Welcome to DC2B Revolution, helping chiropractic students think big in order to live large. I'm your host, Noah Volz, and today I'm here with Dr. John Ventura. He's a graduate of National College of Chiropractic and practiced full-time in Rochester, New York for 30 years. He served as clinical instructor in the Department of Family Medicine at the University of Rochester School of Medicine since 1998, and he's been a faculty of the New York Chiropractic College, the Uvalde College of Chiropractic, National College of Chiropractic, and he's also co-owner of Spine Care Partners and Primary Spine Provider Network. Dr. Ventura, thanks so much for being here.
Thank you, Noah. Pleasure.
Yeah, it's great to have you on the show. Somebody with so much experience and such a wide breadth and range of experience. So, it's always hard to know where to start when you've done so much. But let's go ahead and start by talking about what you do with Spine Care Partners. I know that it's framed as a consulting company, kind of taking the interests of insurance, physicians, hospitals, and creating this kind of spine pathway. Can you talk about the work that you've been doing there and how that might be relevant for chiropractic students?
Yeah, absolutely. And there's a tie in there that I think has great relevance to chiropractic students. Our work I've been engaged in quality improvement programs for the latter half of my career, and on a national level with the United States Bone and Joint Initiative, with the Center for Medicare and Medicaid Services, with the National Quality Forum, with NCQA, the National Committee on Quality Assurance Back Pain Recognition Program. So I've had a lot of experience in working in quality improvement programs. There is probably no condition greater in healthcare than spine care that really needs quality improvement. It's wide variation in care. There's guideline discordant care. In spite of all the good guidelines, people are just not following best practice. Scott Haldeman and Simon Desjardins did a wonderful paper outlining the supermarket of spine care, where there's well over 200 different treatment options. Costs of spine care related to the direct costs of care, which is what pays for the care, and the indirect costs, which is that which pays for disability and impairment. It's probably in the upwards of $200 billion a year for both of those. So it's an astronomical problem. When you start to look at what will help to improve that problem, what will help to solve that problem, to actually bring value to the delivery of those services, then you have to start looking at what value really means. What is, and believe it or not, there's a very operational definition of value in healthcare. We throw the term around a lot without really thinking of it in a quantitative context. You look at it much more qualitatively. And quantitatively, value is outcomes balanced that are really meaningful to the patient, balanced by the cost to get those outcomes. So, the easiest way for people to understand this, and I think students can understand this, is to think of value with a car, right? Are you familiar with the Bugatti Veyron or the Bugatti Chiron?
No, I'm not.
Oh, well, it's a handmade car, and the Veyron costs $1 million. The Chiron is now close to $2 million. So would you consider that a good value when it's a car? It's a street legal car you drive from point A to point B. In spite of how much quality you're getting, it's $1 million for a car. That's not a good value. And you're too young to remember a car called the Yugo, which was basically out of paper mache. It cost nothing, but the quality was horrific, and it didn't last very long. So again, would you consider that a good value? Well, no, the price is cheap, but it's horrible quality. You want the Ford Fusion, you want the Toyota Prius, you want the Honda Civic. You're getting a great car for a reasonable cost. That same formula is now being applied to healthcare. And payers of healthcare, which are the insurers and who people forget, the employer groups who really ultimately pay for healthcare are looking for value. That's really what drove our movement towards this continuum of care pathway that we now sell in Spine Care Partners. And what that model does is it brings effectiveness and efficiency to care. It solves the value equation. Our tagline is, we bring order to the chaos. And in doing so, we've been able to demonstrate savings of over 30% while improving the quality of care, the outcomes that are meaningful to patients. So when you start to implement and apply that model, what it necessitates is that you manage care at the front end really effectively and efficiently. And most people know, the majority of people with back pain, who do you think they go to?
Probably their GP, their primary care person.
Exactly, Noah. 40 to 50% of people with back pain see their primary care physician as the first touch provider. If you look in what a lot of people don't realize is that the second highest provider group that's seen as a first touch provider in back pain, chiropractors. Chiropractors see between, depending on what reference source you look at, 30 to 40% of spine pain as the first touch provider. So whatever model that's developed that's going to bring effectiveness and efficiency to spine care has to engage primary care physicians and chiropractors. And I'll highlight for you how important that is. If you look at money in healthcare that goes to pay providers, primary care physicians only account for about 6% of the budget, right? Only about 6% of healthcare dollars actually pay the primary care providers. Of the remaining 94% of healthcare dollars spent, 80% of that is determined by what the primary care physician does with the patient. So even though not much money's going to them, where they send the patient makes all the difference in the world. Chiropractors bring incredible efficiencies to the delivery of spine care. There's plenty of evidence now in the literature to show those efficiencies. If you look at, they did one study where they compared chiropractic, physical therapy, and medical care and looked at the disability associated with an episode of work-related back pain. The shortest duration of disability were those patients whose first touch was with a chiropractor. We also know that chiropractors, another study showed that chiropractors are ordering the fewest MRIs early on in the course of spine pain. And a wonderful study by Webster showed that early MRI leads to delayed recovery and at least $13,000 per case of additional costs. So if you can use a chiropractor at the front end, you can greatly add to the effectiveness and efficiency of the model. And that led to the development and the promotion of this idea of a primary spine provider. So it's the principles of primary care, but applied to spine. And the person we have to thank for this is Scott Haldeman. You're familiar with?
Oh yeah, I'm familiar with his work.
He's out in your neck of the woods in California. He's at UC Irvine. And Scott, for those who don't know, is a DCMD PhD and a researcher, probably one of the foremost researchers in spine pain in the world. And it was really Scott who promoted this idea of the primary spine care provider. And his whole model, you're familiar, I know you're familiar with World Spine Care because you interviewed one of the docs. Scott has he's implemented the primary spine provider model within these clinics that he's opening around the world to help the disenfranchised, the poorest of the poor, get really good spine care. So we all have Scott to thank for promoting that model of primary spine care. And for the students listening, go to the library if you don't have it and get a copy of the biography of Scott Haldeman written by Reed Phillips. And the last chapter, if you read none of the rest of it, read the last chapter. It's written by Scott himself. And it describes why the primary spine provider model is so important and why the chiropractic profession would be really well advised to adopt this as a collective identity. So that's what we're really helping to try to push and promote. Spine Care Partners is a company we've started to try to develop opportunities to implement the primary spine provider model so that we can bring efficiencies and effectiveness to spine care.
Yeah, and in terms of spine care partners, I'm wondering. You mentioned the car analogy. I'm wondering how you feel the value currently as it's being delivered in spine care. Like, what model of car is currently being delivered? Because obviously we want to deliver the Honda Civic or the Toyota Prius.
You'd have to think of a very expensive car that's relatively poor quality.
Got it.
And this is the difference between healthcare and the auto manufacturing industry. The auto industry, right, would never tolerate a very expensive car that is of poor quality. Right?
Well,
but we tolerate it in healthcare.
They would bring the car back, right? They'd be like, this is too expensive. There's no value. Take it back. But healthcare, we don't have that option.
We don't have that option in healthcare. And so we tolerate inefficiencies and ineffectiveness and waste. And again, in any other industry, it would just not be tolerated. So yeah, there is no car that I can think of offhand that would describe the current healthcare industry. It would have to be an expensive car that doesn't run very well.
Well, hopefully we can change all that.
Yeah.
And the other question I had for you, in terms of what Spine Care Partners is doing is, if 6% of these GPs who are only making 6%, but they're kind of directing traffic, so to speak, in terms of where the rest of the money is spent. What's the best? Is there a way for students to work with them, to educate them? I mean, besides the phenomenal research that you mentioned, what's the best way to kind of raise the brand value of chiropractic so that they consider us when they're making those decisions?
Yeah, I would really suggest that students become very familiar with the whole primary spine provider model and movement. I mean, that's my bias, Noah. I have to say
it's not only your bias, it's the bias of many of the guests I've had on the show that say, really for multidisciplinary care, this is the way to go.
Yeah, it truly is. The criticism, I was on a panel with Mike Schneider. Do you know Mike? He's a DC PhD at the University of Pittsburgh. And Mike and I spoke, and we had a very friendly, because he is a good friend, debate with Jim Winterstein. Jim was the former president of National College of Chiropractic at an ACA conference. And Mike and I spoke in favor of adopting the PSP, the primary spine provider model, as a collective identity for the profession. And Jim argued against that. He thought it might be too limiting. But when you consider it's what we're trained in, right? I mean, the bulk of our training is in musculoskeletal care, most of it around spine. It's what we're paid to do. It's, if you look at what chiropractors are reimbursed for, it's those kinds of services. If you look at scope of practice, it's very consistent and very much in line with our scope of practice. So it's what patients come to us for, by the way. Cher Hawk did a wonderful study where she looked at practices that said, I'm not a back doctor, right? Chiropractic practices, and looked at what kinds of conditions patients were going to them for. Even in the doctors who said, I'm not a back doctor, a chiropractor who said, I'm not a back doctor, more than 50% of their patients were there for back or neck pain. So even in the ones who say that that's what they do, it's typically 90%. of their practice. So it's what we do. It's what the public knows us for. It's what we're really good at. If you look at the effectiveness and efficiency studies, it's what we're really good at. So it's not at all limiting. There's an interesting point that I like to make, Mike Snyder will make, and my business partner, Don Murphy, will make. And that is, once you gain trust of the provider group, right, by adopting this PSP role, if you will, they'll send you everything. You know, I had a neurologist who trusted me so much. He sent me a patient with Arnold-Chiari malformation with a chief complaint of neck pain. Right? I mean, how much trust do you have to send that patient to someone who does manual therapy? So, and then, you know, you get all manner of extremity condition. It doesn't mean chiropractors can't still be sports focused providers, or even focus in women's issues, women's health issues, or pediatric issues. But when you adopt this role as our identity, as our collective identity, then we gain trust. You're familiar with the enigma of chiropractic? I'll summarize it for you succinctly here. There is a great enigma in our profession. And that enigma is characterized in two key points. The first is we score the highest of all health professions in managing back pain on patient satisfaction scores. Every survey that's been done, chiropractors score the highest. However, on scales of public trust, and there have been 3 large Gallup polls looking at this, chiropractors score the lowest of health professions. We score higher than attorneys, but the lowest of health professions. And then the second component to that enigma is they've been tracking utilization of chiropractic services since the 1960s. And every decade, they'll come up with a new study looking at our utilization. It has never varied more than about 2 percentage points above or below 8% of the population. So we only see about 8% of the population. In spite of all the advertising, in spite of everything we've done, it never varies much more than that. But the interesting component is, if you look at a specific condition, back pain, chiropractors see 30 to 40% of back pain as the first touch provider. So we've got this interesting kind of a tension within our profession. I think the PSP model will help to solve that. I think it will help us gain tremendous trust with the public. And think about this. All we really have to do is move the needle up a bit. If we went from 8% of the population coming to chiropractors to 12 or 13%, every chiropractor would be so busy they wouldn't know what to do. So we don't have to make massive changes. We don't need to see 50% of the population. We only need to bump it from 8 to 12 to 15. And it would just make a tremendous impact on our profession. So there's, you know, as I said to the students, get a hold of the biography of Scott Haldeman, and if nothing else, read the last chapter. And secondly, there's a wonderful article that a couple of my business partners and colleagues wrote promoting the primary, I'll send you a copy of it, the primary spine provider model. And it was in Chiropractic and Manual Therapies back in 2011. And it really outlines how the PSP can be of great benefit to the healthcare system. So read those 2 things to help get a better appreciation for what the advantages of this model are. A second company we formed is the Primary Spine Provider Network. If you look at the current website there, it's old, it's outdated, it's really not very functional. We've added a new site, so if I'm going to recommend the students go anywhere, it's to a site called spinecloud.org. And that's the site where we're building a community for people interested in the primary spine provider model. And there's a free membership section. So you can sign up as a free member and get access to all sorts of information. We're working with a tech genius from South Africa, who we've partnered with. He worked with us, and we formed a new company, Spine Care International. So we now have a subsidiary in South Africa. We have a subsidiary in Australia, and we're looking to expand even to some other countries. But we're going to soon move everything from spinecloud.org over to primaryspineprovidernetwork.com, but that hasn't happened yet. So just as a resource, going to spinecloud.org, you can sign up as a free member and get access to a lot of the information that we're going to be promoting about why and how functioning as a PSP helps.
Yeah, I'm currently a member of spinecloud.org, and I can totally endorse it. I agree that there's a lot of really great information there. And I really like how you kind of laid that out, talking about how we're seeing, 30 to 40% of the back pain patients, how how patients are really enjoying the chiropractic approach. There's a lot more satisfaction with that, and how there's this huge need where it's too expensive and there's not a ton of value there, and so it feels like we're uniquely positioned. And as you said, because the word chiropractic or chiropractors in general as a profession don't have a lot of public trust, kind of moving things towards this primary spine care provider credentialing and almost brand image. It seems like a win-win for everybody, because then you're kind of positioning yourself perfectly to really help the patients that need the care that we can provide.
Yeah, and I'm going to give you a little bit of a caution that I would recommend sharing with the students. And this caution has been mentioned by Dr. Haldeman. It's been mentioned by Dr. Schneider at UPenn. And it's part of the model we're teaching. When we teach the PSP model, we like to say that it's degree agnostic, right? It's about a skill set and about a role. And consequently, as Dr. Haldeman has cautioned us, and he outlines in the last chapter of his book, it's ours to lose, so to speak, this primary spine provider role. If we don't, now mind you, most people don't understand this either or realize this. Most physical therapists don't, because I've lectured to quite a few of them. What percentage of back pain do you think physical therapists see?
I think it's high, probably like 80%.
No. I mean, they may see a lot of patients for that, but only about 10, 15% of back pain patients go to PT. Primary care is not referring a ton of patients with back pain. And that number came out of a research article, and also by my own communication with a well-known researcher in the PT world. But however,
so where are those back pain patients going? Just well, quickly.
Primary care physicians and chiropractors.
Got it.
And then with the primary care physicians, a group I'm a part of is the United States Bone and Joint Initiative, and our mission, it's a national initiative that came out of the Bone and Joint Decade Research project, which Dr. Haldeman was one of the lead researchers on. And the initiative now is to carry on the work of the decade and to promote education, research, and understanding of musculoskeletal disorders, right? And one of the initiatives that we started in our group was by an orthopedic surgeon in UPenn, Joe Bernstein, and that was called Project 100. What we know is medical schools are doing a terrible job of providing musculoskeletal education, yet it's one of the most common reasons people go to their primary care physician. And in fact, our newest initiative, which I'm on the steering committee of, and we, by the way, have 3 chiropractors as a part of this, Jim Eubanks, who's a new chiropractor, but a new medical graduate, now doing his residency in physical medicine and rehab at UPenn, and Gene Lewis, who's a chiropractor at Duke University. We're all 3 a part of this project, which is to develop a musculoskeletal education curriculum for fourth-year students in medical school that are going into primary care, because they just have a terrible background in education in it, yet they're seeing 50% of spine pain as the first touch provider. And by surveys of primary care physicians, they don't feel they've had adequate training in it. And many of them, not all, but many don't really care for it. Internal medicine tends to not like back pain. Family medicine tends to like seeing back pain patients. But by and large, neither group has had sufficient training. So we are, I mean, there's a great niche that needs to be filled here, right? Somebody who can function as the primary spine provider. If we don't adopt this and really engage with it on a large scale as a profession, I have no doubt that the physical therapy profession will be more than happy to take over the role. So that's the caution.
Yeah.
As Dr. Haldeman says, it's ours to lose, right? We are the best suited, by the way. When you define the skill set of a primary spine provider, the most highly qualified group out there is most definitely the chiropractic profession.
Yeah, thank you. Thank you for that caution. And you mentioned training. I know I'm inspired. I hope a lot of the other students who are watching this are inspired to go this route, to become a primary spine provider, to not lose this opportunity. So where is the training currently? And above and beyond signing up at spinecloud.org, what is the best way for students to kind of find out about the training and learn more about that?
Yeah, I want to be careful in how, in mentioning training, because, and I don't, do you know Christine Gertz, Dr. Gertz?
Yeah, I interviewed her for the channel.
Oh, great. Christine's just wonderful. And we've had this discussion, and she makes a really valid point. We don't need, and we don't, by the way, we don't need additional training as chiropractors to function as primary spine providers in a system right now. Plenty of people are doing it without any additional training. But we think there are several skill enhancements, and there's an identification of gaps in care, right? So if we look at, again, the skill set in the model of a primary spine provider, a big component of it is that you function in a biopsychosocial model, right? Medicine historically has been hierarchical, the doctor is the expert, and very mechanistic and reductionistic, right? And we want to move away from that into a biopsychosocial model where the biological, the psychological, and the social constructs are all dealt with. So in the training that we do, the short course training, which is just 24 hours, where when we have a client like an insurance plan, a Blue Cross Blue Shield plan, and they want us to train the chiropractors in their community, we do that in a short 24-hour program. And it really, and the way I frame it always is, this isn't to teach you a ton of new skills. If manipulation, differential diagnosis, it's to help you identify gaps in care. And one of the biggest gaps that certainly is out there in practicing clinicians, schools are getting better at incorporating this, and that's the psychosocial assessment and management. So, not many providers are really incorporating psychosocial assessment tools. The one we really are big on and really push is the Start Back screening tool, 9-item screening tool, if you're familiar with it. It's all
only
free.
From your videos.
It's all free and downloadable. Just go to, it's Keele University did this work, and it's all free and downloadable. Just go to Google Start Back tool. And it's a 9-item questionnaire that is valid and reliable to identify those who are at risk of chronicity with back pain. So the first couple of questions are just about your pain and where your pain is. The next couple of questions, we're actually taking off the Roland Morris disability scale, and they're about function. And then the next 5 questions are 6 questions are all about psychosocial aspects of your pain experience. So it becomes a valid predictor of who's at risk to become chronic. So there's a really simple tool. So now if you get somebody who's considered high risk for chronicity when you see them on your first visit, you can treat them with some kid gloves. You want to really make sure that you're using a low risk lexicon. You don't want to use any language that could be misconstrued as catastrophizing. You want to make sure you're using language that's self-empowering and motivating to these people. So yeah, that's so the training is really about helping you identify gaps in care. We do offer that program on the pain section of our website, but aspects of it are really on the free part of that website too. And like I say, a chiropractor with the training that they have right now can function in a PSP model. What we try to do is just skill enhancement. Teach you some skills that we really don't get in school, like how do you effectively communicate with physicians? And that's, on the spinecloud.org website, and those are all free resources that you can access. So, you can function in that role now. We think there are certain skills you can really enhance. And we're going to put as many as we can. We're only really building out the content for that site. So we will look for feedback from all those who are part of that community to say, here's what I really need. Here's an opportunity I have. How should I approach this? And we're always happy to try to share that kind of advice. The more chiropractors we can see operating in these multidisciplinary integrated settings, the better it will be for our profession as a whole, because it builds trust. And that's where we're really lacking. We gain trust, and boy, our profession is just going to soar.
Yeah, I completely agree. I feel like that's really the limiting factor to chiropractic at this point is the public trust. And I really feel like these resources that you provided, the enhancement that you're providing on our skill set, especially when it comes to the biopsychosocial model, is really going to help anybody who is communicating with any patients, because it's just going to help them be better at what they do.
Thanks,
yeah.
Noah. Yeah. I'll give you just a quick little anecdote here. I'm from Rochester, New York, and the term biopsychosocial medicine was coined by a physician from Rochester, New York, Dr. George Engel. He was a psychiatrist at the University of Rochester. And I was fortunate enough back in the late 90s or early 90s, I can't remember. I was part of a biopsychosocial study group at the University of Rochester. I've been on faculty there. I'm still a faculty member at the University of Rochester School of Medicine. One day, an elderly gentleman came in, and they were going to convert the entire curriculum at the medical school to a biopsychosocial curriculum. And so the dean of the school was there in a big crowd, and this elderly gentleman started to ask a question, and his question just went on, and everybody sat in quiet deference to this guy asking this question. And I leaned to the woman next to me and said, "Who is that?" And it was Dr. Engel. It was shortly before he passed, so I had an opportunity to see him, not converse with him, but at least see him. But that whole model now, it's a shame he's passed, because it really is driving a lot of the change that's happening in healthcare.
Yeah, and I think it's really creating, like you said, that multidisciplinary, team-based medicine, collaborative medicine component. It gives everybody kind of a common language that they can use to work together.
Absolutely.
And I think that's what we all want.
And the patients will be the ultimate beneficiaries.
Yeah, and that's really what it's all about, right?
Yeah, totally.
Yeah. Well, thank you so much for coming on the show today, sharing, all of your wisdom, sharing this new information for students who haven't been exposed to that, giving them some resources, places that they can go to get more information, and really dig in and and be part of this community and part of this movement.
Wonderful. Wonderful. Thanks so much for this opportunity, Noah. Great speaking with you.
Yeah, you're so welcome. So this has been a production of DC to Be Revolution, helping chiropractic students think big in order to live large. If you like this video, please share it with your friends, subscribe to the channel, leave some comments in the comment section below. It's always great to hear from people, and until next time.